here, and then it's a CME. I will put the CME link in the room at the end of the lecture. But understand this is CME. You can get 2 hours from it, from American Medical Association Category 1. And and as you see, the topic here is Amlexanox, the clinical application of Amlexanox. And this molecule, it's a miracle molecule because it has many different um, activities and mechanism of action to navigate many conditions, almost all chronic disease out there, including inflammatory disease, cancer, um, metabolic disease, even some tumor cancer, and also genetic disease, especially the nonsense mutated genes. And we're going to understand how the Amlexanox work and the protocols, the proposed protocols. And I'm encouraging everybody here to start using it. And you can use it by the compounding pharmacy can compound it for you. And I think um, um, you can easily resource it from the compounding pharmacy. So clinical application of Amlexanox. We're going to talk about the mechanism, protocols, and dosage, and managing allergy, metabolic syndrome, cancer, chronic diseases, and nonsense mutation genetic disorders. That's a very important one because we don't have any drug that can touch nonsense mutation genetics. We don't have drugs that touch cystic fibrosis or muscular dystrophy. And I have patients that did very good uh, with amloxanox, especially if they're with mild, moderate cystic fibrosis. They will do very good with amloxanox, and they will appreciate it if you start giving them or prescribing them this medication because it's the only hope to revive the proteins of the cystic fibrosis, the channels of the chloride, which is missing. That is very important for the sweat glands to function and secrete normal sweat. You need those chloride channels. Um, and and uh, and Amloxanox helps to revive the production of those proteins that's been degraded because of the nonsense mutation in the genes that express those chloride channel proteins. And we're going to talk about it more detail when we go to the slides. Um, Sheldon, please add the people because now I don't see the room anymore because my screen is
We
full
have
of the
14
lecture.
participants right
Yeah,
now.
so please, if you can invite them.
I'm doing that.
Thank
I
you very
will add
much.
more.
Amloxanox initially used for aphthous ulcer. That's the first FDA approved. And then they discontinue it here in the United States for no reason, just because they find other alternative drugs that the big pharma can profit from, um, and to treat ulcers, aphthous ulcer. But really, nothing works better than Amloxanox. Just it happened. Those big pharma, they wanna and make money, so they do some catch and kill sometimes. And when they invented something and they want to sell it, they even kill the one that does work better, right? Um, so Amloxanox initially used for aphthous ulcer. It's still FDA approved here in the United States for aphthous ulcer, but they don't bring it the big pharma. But the compounding pharmacy still can make it for you. And in Japan, they use it for allergies, for asthma. So it's good for allergic condition because in the beginning it was a drug that works as a mast cell stabilizer. So it's good for mast cell activation syndrome and allergies. It inhibits the TH2, by the way, but it also it inhibits the TH13, TH17. Um, so it's emerging as a promising therapeutic agent for metabolic syndrome. And we're gonna see how because it inhibits the pro-oxidant enzymes that generate free radicals, and excessive production of pathological free radicals can lead to oxidation of the insulin receptors and um, insulin insensitivity and diabetes. So if we inhibit those excessive production of free radicals, we may able to regain the activities of insulin receptors and sensitive insulin receptors. And that's the way we manage diabetes, especially type 2, instead of giving them insulin, because insulin, too much of it, insulin itself is free radical generators. And if you give them insulin without increasing the insulin sensitivity, uh, you know, which we have many methods of doing it, um, by amloxanox inhibiting the pro-oxidant enzymes, or by also managing the leaky gut syndrome, because those guts can leak free radical generators, which cause an activation of insulin receptors. So there's many ways, or by detoxing the body. And if the big pharma relies on just insulin and without looking at other methods to increase sensitivity of insulin, the insulin itself can become free radical generators, and they can cause oxidative stress, leading to more blockage of those insulin, more insulin resistance, more insulin you need. And that's the reason those patients, they end up with oxidative stress that leads to oxidizing the LDL, leads to atherosclerosis, and they end up with severe vascular problems, angiopathy, and stroke, and infarction. And the reason why, because um, using insulin and statin is not that answer anymore. I mean, it can be part of the treatment, yes, but they need to find alternative to statin insulin. You need to look for the root cause. Statin have the cholesterol, and we have a discussion in those rooms about statin use for long term. Now, inhibiting cholesterol, that's fine for short term. Yes, statin is good. It also stimulate a little bit the NOx enzyme, generate nitric oxide, which helps endothelial function in the beginning. But also statin interferes with the mitochondria. And when you interfere with the mitochondria, you generate oxidative stress. And statin also inhibit the cholesterol synthesis, which leads to inhibition of sex hormones. And when you decrease the sex hormone, you end up with oxidative stress, right? Because sex hormone are regenerative, they express antioxidants. And when you do that, you end up with oxidative stress. You oxidize the LDL. The LDL will end up in the macrophages of the blood vessels. They form plaques of macrophage containing foams of oxidized fat, plaques, atherosclerosis, right? And it will aggravate atherosclerosis with long-term use. So what will be the answer? I think the answer is cyclodextrin, right? Loaded with EDTA, because atherosclerosis is not just deposition of oxidized fat, but also it's calcium as well. Calcium deposition on the blood vessels and become rigid. And so to manage atherosclerosis, you really need to work to chelate the body from those fat soluble toxins, which cyclodextrin can do that, and also chelate the excess calcium that's being deposited in the blood vessels. And if you do that, then you can help really manage the root cause of atherosclerosis. In addition to that, there's fibrosis. So there's fibrosis, calcium deposition, and there is what? And there is the oxidized fat, right? Oxidized LDL. And we need to work on those three. Now, how we can do fibrosis? Clotho will be the answer. Clotho is antifibrotic. What else you can think about? Losartan. I like losartan a lot. And losartan is anti-aging, just even low dose, 50 milligram a day. It will not do much on the blood pressure, by the way. Um, so losartan will help, and amloxanox, as we learn here, and cyclodextrin. And then you need to have some ADTA to get rid from the calcium. Um, so it's a promising therapeutic agent for metabolic disorder and cancer, and for two reasons: cancer because it activates the P53, right? by the nonsense mutation, if there's any nonsense mutation in the p53. Plus, it does inhibit the Th17 and Th2, which allow the immune system to be polarized into Th1 and cytotoxic T cells. So this is maybe two mechanisms. In addition to that, amloxalox inhibit the pro-oxidants, and we know that the cancer survive in higher free radical potential status than the normal tissue. And if you lower it, then possibly you can induce apoptosis. So there's two way of getting in from cancers: either increasing it to induce apoptosis or lowering it. Both will help to get rid from cancer because cancer lives in a redox potential higher than the normal tissue. They cannot proliferate in a normal redox potential. They need higher redox potential. And those pro-oxidant enzymes, we're going to learn about them. They keep the oxidative stress of the cancer that helps to flourish them and make them to grow and proliferate. And if you either lower them by amloxanox, that helps induce apoptosis, or you induce more free radicals, and that can be done by photodynamic therapy. And both way can help to induce apoptosis. And because it inhibits the Th17 and Th2 and all the cytokines, interleukin 6 and interleukin 4, so it's good for the chronic inflammatory disease. Because most of the chronic inflammatory disease, they do have hyperinflammation of Th17. Autoimmune diseases, whether it's Th1 dominance or Th2 dominance or allergies, they do have components of hyperactive of Th17, and amloxanox inhibit that interleukin 6 and Th17, so it's a good drug for managing autoimmune disease in general. And again, it's good for managing genetic disorders because they help to prevent the breakage and decay and of those messenger RNA who has stop codons that express the missing proteins that leads to the genetic disease. They inhabit the breaking those messengers, so they allow those messengers to be to be expressed. Even they have not stop codon in them, so they prevent the enzymes that read the stop codons and break them from happening, and they override that blockage. Um, so its mechanism of action is include inhibition of inflammatory pathways. We talked about it by inhibiting the pro-oxidant enzymes pathway and inhibiting the Th17 and Th2. So they inhibit the inflammatory pathway. The enhancement of metabolic function. When you decrease the free radicals and oxidation of the insulin receptors, definitely increase the insulin sensitivity. So it's good for metabolic syndrome. And facilation of nonsense mutation. So it helps to override the nonsense mutated genes and express them, and so that you can manage cystic fibrosis who has a nonsense mutation in their genes of the chloride channels, because this amloxanox will override the breaking of the messenger RNAs when they start um, um, when they're being released. There's enzymes that they check. Oh, this has stop codon. This messenger, we need to break it down, terminate it. That enzyme is going to be blocked by amloxanox. So it's overriding the breaking down of those nonsense mutated genes. Um, so they help to facilitate of the nonsense mutation red throw, making it a versatile candidate for multiple clinical applications. I never seen a molecule that has this broad spectrum of effect like amloxanox, especially, you know, managing nonsense mutated genes. We don't have any drug can do it except amloxanox. That's why it's very unique. And I like to thank Dr. Joseph James. He's the one really to who brought the attention to this molecule. And then I invest into this molecules and I expand the understanding it and I start presenting it. Same thing I did with Metlan Blue. Metlan Blue at time in 2016 and 17, nobody hear about it. And if you go to Amazon, you don't see anything except those lab made Metlan Blue. It's not for human use. But I recommend it a lot in my education platform. And now today, Amazon, if you click on Metlan Blue, you will see almost 50 to 60 companies producing Methylene Blue for human use. A time when we have COVID, only two companies, and it's only for research use. Now there's 50 or 60 companies producing Methylene Blue as a supplement published in Amazon right now. And that's the reason education does have influence in shaping medicine. And we are the one who can shape medicine. Um, me and you and everybody here, although it's a small group, but we are causing tremendous change in advancing medicine, even with this small group of doctors. And the reason because we are all the time looking for the problems and trying to find solutions. With the collaboration of all of you, we definitely can redefine and direct and innovate and have better way of treating patients. So I have a book. It's called "Make America Healthy Again." By the way, for everybody here, and if you just click my name in Amazon, it's a good book for everybody to read. Um, and I think I'm gonna write a book on Amlexanox because it's very interesting molecule, along with methylene blue, Amlexanox. I mean, ivermectin is good, but I think it got a lot of attention, which is enough. But Amlexanox needs some more work. Needs to be done on Amlexanox. Um, are you adding people because I can see Dr. Narius there? Okay, let me see here. Sheldon, are you there? Shell.
Yes, he's
Because
admitted. I
Nari
admitted
was
him. I
on the road.
invited
Yeah.
him and admitted him.
Okay. So we're gonna go through this slides. It's only 10 slides. Um, and we're gonna learn exactly the mechanism function of amlexanox and the dosage and protocol. So everybody here we can start using it because we have the protocols and yes, it's good for COVID-19. And Dr. Iman Bar is right in that. Um, So the mechanism of action of amlexanox, how it works, it inhibits the TBK1 and IKKE. Those are pro-oxidant enzymes and epigenetics. And when they are being overexpressed abnormally, pathologically, especially in cancer or inflammatory diseases, autoimmune, it generates too much of pro-oxidant, which activates uh, those lymphocytes, hyperinflammation, and they need to be suppressed or normalized their activities. We still need free radicals because there is physiological level of free radicals very critical to stimulate the expression of the genes. But too much of it, it can be inflammatory and destructive. So we need to normalize it. We need to buffer it. Amloxanox will be the answer. And so the TBKI, it's tank binding kinase. So they're kinase protein. And kinase, what they do, they phosphorylate. That's how they do. They phosphorylate the enzymes and activate those pro-oxidant enzymes. So they are pro-oxidants and they generate free radicals, like NOx enzymes. They activate NOx enzymes and NOx enzymes expression. And when you have too much of free radicals, it leads to activation of and hyperinflammation, especially the TH17 and TH1, TH2. Um, and that's it. It also stimulates the expression of interleukin 6, and it leads to shifting of the immune system to TH17 and TH2. And that's why it's good for allergies. It's good for autoimmune disease that is TH17 dominance, especially. Um, and yes, it's also good for cancer because we have too much of inflammation, especially TH17 and TH1, TH2. Really, those inflammation cannot do anything with cancer because TH17, what will give you? Give you neutrophils, right? And TH2 will give you basophils and mast cells. What the mast cells and eosinophil would do and the neutrophils would do for cancer? Nothing. We need Th1 and cytotoxic T cells. And inhibiting Th17 and Th2 and polarizing to Th1 is a good way to manage cancer. So this will lead to reduction of inflammatory cytokine production, which is the Th17 especially, interleukin 6, interferon gamma, interferon beta, tumor necrotic factor. Those all they really activate the Th17 and they suppress the chronic inflammation that's Th17 dominancy, like rheumatoid arthritis. Um, what else? Lupus, systemic lupus also. They are Th17, multiple sclerosis, Th17 dominancy as well in it. And when you reduce those excessive free radical, pathological free radicals, you decrease the oxidation of insulin receptors, you increase insulin sensitivity, and this will reduce adipose tissue inflammation, right? Because those fat tissue and the visceral fat tissue, those excess fat that we have in our viscera, it's releasing a lot of interleukin 6. Those fat tissue are inflammatory cells. So when you see somebody obese, it's not normal. He's inflamed. Those fat tissue in the viscera, they are having Th17 active, and those fat cells release interleukin 6 and aggravate Th17 and cause Th17 inflammation. And when you cause Th17 inflammation, you activate the NOx enzymes and generate free radicals, and those free radicals will block that insulin and cause insulin insensitivity. So it's very important, and I think in the future that anybody has extra weight is considered pathologic. It's considered sick, although he is not manifesting clinically. And for now, standard today say, oh, he's just obese. No, and it will come one time where the obese is considered sick and he cannot even go to work. He needs to go and reduce his weight because it's going to be a burden for the health system. And same like smoking. Obesity will be like smoking, where it's going to be prohibited. You cannot go to work and you're obese. And the government and the health system will support you to reduce your weight in order to go back to work. This is how much um, it's going to be in the future because those fat tissue, in addition, it is source of inflammation, metabolic syndrome, and all the disasters that we have, and shifting the immune system away from cytotoxic T cells and compromising the immune surveillance against cancer. So it puts the patients cancer and autoimmune diseases, a lot of problems, and we need to work with education and cognitive therapy that the patient needs to be in optimal weight as part of his health, and also reduce the burden over the health system. In America, 60% of adult population are obese, and that's a disaster. And that's the reason why we're paying too much for the health system and there's no outcome. And the reason because we are not looking to for the root cause of the problem. And obesity is the root cause because it's a source of inflammation, source of Th17 hyperactivity, source of NOx. Though they have activated TBK1 abnormal active, and they're producing too much of free radicals. And that inflammation needs to be suppressed. Amlexanox will be one way of doing it, but GLP-1 will be another way. Metformin, although metformin can lead to a problem with absorption of vitamin B12. So anybody takes metformin needs to be taking B12, by the way. And so we need to restore the homeostasis of the sugar and improve the glucose homeostasis and metabolic syndrome by giving Amlexanox will be one of the answers. And again, if we give Amlexanox, definitely it inhibits the Th17, Th2. It polarizes the immune system naturally into Th1 cytotoxic T cells, so it will improve the tumor surveillance, and it will that will lead to inducing apoptosis, right? Because when you put redox potential, the cancer lower, then this will help in inducing apoptosis, because this extra free pathological free radicals driven by TBK1, driven by those kinase proteins, if we suppress them, we can normalize the redox potential and possibly induce apoptosis. So either way, increasing the free radicals higher than the cancer can tolerate or lower than the cancer can survive on, both that approach can lead to apoptosis of the cancer. Okay, so we talked about Amlexanox. It's good for metabolic syndrome. When we say metabolic syndrome, what is it? It's obesity, hypertension, hypercholesteremia, and diabetes, right? Those are metabolic syndrome. So it improves insulin sensitivity, and also it reduces obesity-related inflammation because it inhibits the Th17 and interleukin 6, right, from the fat tissue. And so we can use it for managing chronic inflammatory disease in general, especially the Th17 dominant inflammation. It suppresses the NFK beta mediated inflammation because they generate free radicals that irritate those lymphocytes, especially the Th17. And it definitely lead to reduction in tumor survival. Why? Because a tumor relies on higher free radical potential. They live in redox potential that's higher than the normal tissue. And if you reduce that, you may induce apoptosis. It's not compatible for the cancer to survive in a lower redox potential. Um, okay. Now, the other thing is that for Amlexanox, it's good for treating nonsense mutated genes. And why? Because they override the nonsense mutation rethrow. They override the blockage and breaking down of those messenger RNAs. So when you have a mutated DNA that has stop codons, and then when those mutated DNA or genes, they're expressing messenger RNA, there's enzyme when they see the stop codon, the messenger RNA, they will grab this messenger RNA and degrade it, break it down. They will not allow it to be expressed or pass. That enzyme that breaks those messenger RNA who contain stop codons and those messenger RNA that express very critical protein and a deficiency of it can lead to genetic disease. Like, let's say this messenger RNA is expressing the chloride channels of the sweat glands and it has stop codon, right? And that's the reason it's not being expressed because the enzyme, when they find this message and they read the stop codon, they go ahead and shred it. No, this messenger will not pass and will not be expressed by the ribosomes. So those patients, they will not have chloride channels. They end up with cystic fibrosis, right? You need the intact chloride channels to produce normal sweat. Otherwise, you end up with a salty sweat, right? Because you cannot absorb the salt back. And why? Because those chloride channels are blocked. They cannot allow the chloride and sodium to go back to your tissue. Um, and so this Amlexanox inhibit that enzyme that breaks that messenger RNA that reads the codon stop codons, allowing this messenger RNA to be expressed, the protein to be expressed, and the patient will restore those functional protein synthesis. That's a good thing. And we don't have any drug that can do that except Amlexanox. So now we have, as a doctor here, we open the Pandora uh, can, right, for managing nonsense mutated genes. Any nonsense mutated genes, there's potential that you can help them. And nobody can help them out there because ignorance, possibly, and possibly those doctors, they follow whatever the big pharma told them to do. But because it's FDA approved drug, you can repurpose it and a lot of patients can be benefit from it, especially cystic fibrosis. You can open clinics for cystic fibrosis. A lot of organizations of cystic fibrosis, they have no answers except some respiratory therapy and mucolytics. Um, but now we have answer. Cystic fibrosis is not just causing respiratory problem; it causes infertility as well, because they block those ducts of the scrotum from the mucus. It become thick and right, and it's causing sterility. And I think now we have some answers to for those patients. And I wish all the doctors here would start, you know, working on those chronic diseases, especially the nonsense mutation. And there are many of those nonsense mutations. We're gonna we're gonna list some of them here in this room. Um, so nonsense mutation, uh, retro and or nonsense mutation introduce premature stop codons, leading to non-functional protein in various genetic disorders. So what happened is that those nonsense mutated genes, when they express those messenger RNA, they end up with stop codons in their messenger RNA, and there will be enzyme will break them down. And if they pass that and they're trying to be expressed to protein through the ribosomes, there will be another enzyme will look, oh, this messenger RNA, we're gonna block it. Well, whoever blocks it, it's gonna be blocked by Amlexanox. So Amlexanox inhibit nonsense mediated messenger RNA decay enzyme. Okay, so that's the decay enzyme is the enzyme that reads and find those stop codons and those messenger RNAs, those messenger, and shred them, preventing it from being expressed into protein. Stabilizing transcripts with those premature stop or those stop codons and promote ribosomal read-through as well. So even if it passed, and there will be enzymes that will try to break this messenger RNA from being expressed through the ribosomes to protein, it's going to be override by the amlexanox. Amlexanox will say, yeah, continue express it even if there is stop codon in it. Does that make sense? Hopefully. So the protein will be expressed, and when the protein is being expressed, the missing protein is gaining its function, and that how we can um, manage genetic diseases from the root instead of just masking it, the symptoms of it. Enable near cognate amino acid insertion and partial restoration of the protein function. There will be restoration of the protein function, which will help those patients to gain and improve their conditions. So cystic fibrosis is one of them. Muscular dystrophy is another one of them. So genetic disorder. So enables the functional protein production in conditions such as, so those are the condition: Duchenne muscular dystrophy, cystic fibrotic, Rett syndrome, and P53 driven cancer. Now, P53 driven cancers, those cancers who has mutated P53. We know the P53 when it's active and normal, it helps to induce apoptosis in the cancer. So if the P53 is abnormal, then those cells will not stop from dividing. Some of those genes of P53 are nonsense mutation, and we can restore the function of P53 and induce apoptosis of the cancer by just giving Amlexanox. So it does have cancer therapy potential here by potentially restoring the truncated tumor suppressor proteins, which is the P53 here. It's a Th2 inhibitor and it's a mast cell stabilization. Originally, this drug was a mast cell stabilizer, and so we can use it for asthma and and allergy in general. Amlexanox stabilizes mast cells, inhibiting histamine and leukotriene releasing. It inhibits the Th2, by the way, cytokines, reducing eosinophilic inflammation, right? And down-regulating the Th2 cytokines, as we talked about. And it provides both systemic and localized anti-inflammatory effect. It also inhibits the Th17. Most of allergic reaction, yes, it's Th2 dominancy, but there is some overactive Th17. So it's Th2, Th17 hybrid, but dominant is Th2. That's the allergy. Autoimmune diseases, that's Th17 dominancy, like systemic lupus erythematosus. It is Th17, and there's some Th2, but its dominance is Th17. So that's the difference between lupus and asthma, for example. Asthma is Th7, Th2 dominant with some Th17 activity, hyperinflammation. Lupus is Th17 dominant hyperinflammation with some of Th2 activity. So in both sides, Amlexanox will help in both conditions. Allergic condition. So reduced symptoms, we can use it for asthma, rhinitis, food allergies, oral mucosal disorder, aphthous ulcer, and there's topical formulation for that. Anyway, it's like a little tablet. You put it on the ulcer itself. Elevate inflammatory lesions and aphthous stomatitis. Um, Clinical application and experimental protocol, allergy and immune. In Japan, they're already using it for allergy for asthma. And they've been used for allergic rhinitis and asthma. There's application in eosinophilic esophagitis, aphthous stomatitis. It's FDA approved one time. Well, it's still FDA approved for aphthous stomatitis. They just discontinued the big pharma because they say we find something better. But I don't think there's anything better than Luxonox. It's just basically catch and kill and looking for some way of making money from other drug that's been invented recently and replace the same thing they did with Metlan Blue. Metlan Blue used to be a powerful antibiotic for um, for inflammatory cystites and UTI. And then a certain way they just discontinue, say, oh, we find better antibiotics than Metlan Blue. But Metlan Blue still works, especially with patient has resistance to those antibiotics. And possibly you can break the resistance by Metlan Blue, especially if you load them with cyclodextrin. That will add more efficacy and the antibiotic effect of Metlan Blue, especially for UTI infection. Um, so there's many forms, oral, tablets, or topical. For topical 5 to 10%. Amloxanox oral paste applied 2 to 4 times daily. Systemic, which is how much a dose? From 25 to 50 milligram daily. And this can be used for mast cell stabilization, for COVID, long COVID, or for allergy, um, or for any allergic reaction or allergic inflammation. We can use this dosage of 25 to 50, or for long COVID as well. Metabolic syndrome and obesity. Again, I did recommend using Amloxanox, naltrexone, metformin as a cocktail for weight loss as alternative to GLP-1, especially if it's loaded with cyclodextrin, that would be better. Um, and it does help in insulin resistance. We know why, because it blocks the kinase enzyme that activate the pro-oxidant enzymes and pathological free radicals, which oxidize the insulin receptors and causing them to become insensitive. So especially for type 2 diabetes. And it's also good for obesity because it decreases the inflammation of Th17 inflammation and interleukin 6 that's being expressed from the fat tissue. And we know those inflammatories and the free radicals inhibit enzymes of the beta oxidation that breaks down the fat tissue. So the oxidation helps the breaking down of fatty acids in the fat tissue. All the enzymes that breaks down the fat, it can be blocked by those oxidative free radicals. Once you reduce those free radicals and by blocking those kinase enzyme, you may be able to restore the function of the Krebs cycle and breaking down the beta oxidation and breaking down the fat tissue. So it's good. It will help to shrink the fat, decrease the inflammation, that leading to insulin resistance, that leading to resistance of burning of those fat because of the blockage of those enzymes. And what will be the dosage? 50 to 100 milligram daily, 40 milligram twice a day, or 50 milligram twice a day, divided dosage. Duration for 3 to 6 months in clinical trials, and they find, there is some reduction of weight. You can get into 10 to 25% of the weight reduction that you're looking for in 3 months and 6 months, and 3 to 6 months. The other part is that it's good for cancer therapy, especially if this cancer is driven by TBK1, which is the kinase that stimulate the pro-oxidants and the free radicals. As we know, the pathological free radicals is the environment for the cancer to proliferate and divide. In lower free radical, low redox potential, the cancer kind of turn into a dormant or induced apoptosis, right? So the cancer likes to live in a higher redox potential than the normal tissue. So it helps to lower it down. Plus, it helps to block the Th17 and Th2, which help to keep the polarized immune system to Th1 cytotoxic T cells. All of these factors helps to make the tumor microenvironment hostile environment for the cancer. And also, if there's any nonsense mutation p53, it will override that, activate the p53 again, which will stimulate the signaling of the apoptosis. The dosage here, 100 milligram daily, 50 milligram twice a day, potentially in combination with other targeted therapy, like, all this therapies that we talked about cancer, that's the anti-PD-L1, anti-CTLA-4, immunotherapy, or low-dose chemotherapy activated with light, or radiotherapy, especially with radiosensitive drugs or radiosensitive pellets like brachytherapy, antifibrotic, anything that changes the tumor microenvironment, Avastin, to make it a hostile environment of the cancer and hitting the cancer from all different directions. So saying that, oh, we got the answers, Amlexanox, and that's it. We solved the problem of cancer. That's not the way, you know. We will be a fool if we start entertaining monotherapy as a treatment of cancer, because cancer is a very intelligent creature and using all the methods to change the tumor microenvironment to be favorable for their growth. Now, we need to work on all the tricks and make that tumor microenvironment hostile, in addition to targeting its metabolism, whether through the chemotherapy or through ivermectin or through mebendazole, those antiparasitic. They say it interfere with the with the cancer metabolism. So you need to target the cancer from all different directions, from the regenerative part, regenerative modulation, activation of p53, for example, inducing apoptosis. From the metabolic part, talking about lowering the sugar or interfering with glycolysis. There's lots of drugs can do that, or inducing free radicals like photodynamic therapy, or ozone or oxygen therapy, or antifibrotic like clotho and losartan, antiplatelets, Avastin to normalize the blood vessels, and anything that inhibits the Th17 and Th1 is a good thing for cancer, including antihistamines, by the way, and including Amlexanox here. And when you treat cancer, it has to be multi-therapy and targeting all different angles of cancer in order for us to have satisfying results. Okay. So Amlexanox can be used for managing inflammatory disease because it inhibits the Th17 and Th2. So it's good for autoimmune diseases like rheumatoid arthritis. It has Th17 dominancy along with Th1. So inhibiting the Th17 is a good thing. Inflammatory bowel disease, Crohn's disease, celiac disease, and also neuroinflammation like multiple sclerosis. Amlexanox will help all this because all this inflammatory disease do have Th17 hyperinflammation. And, using 50 milligram daily, uh, and then titrate based on inflammatory response. Again, we use Amlexanox to manage nonsense mutation genetic disorders. And those are the list of them. Duchenne muscular dystrophy, which affect the muscles due to loss of dystrophin. So this dystrophin, we can regain the expression of it by using Amlexanox, right? Leading to progressive muscular degeneration. Cystic fibrosis affecting the lung and digestive system, and also the infertility system. Um, the right, because the fertility system. Why? Because it blocks also ducts, right? Because of the mucus, it's become thick, uh, salty and thick. The chloride channel is missing. That leads to influx of the sodium potassium back to the tissue, to your blood. That's being blocked, so you end up with losing a lot of salt, and which leading to dehydration of the mucus, and they become thick and blocking your um, bronchus um, and the ducts of the testis and the pancreas ducts, which leads to all this problem that we know for cystic fibrosis. So it's a multisystemic disease, by the way. And we have an answer for some of those patients, especially with mild and moderate cystic fibrosis. They respond very well with um, restoring the cystic fibrosis protein back um, and preventing the thick mucus building up. Rett syndrome is neurodevelopment disorder caused by MECP mutations, and we can this nonsense mutation we can regain its function by Amlexanox. And of course, this deficiency of this protein leads to cognitive and motor impairment. Spinal muscular dystrophy causes motor neuron degeneration and muscular wasting due to the loss of SMN proteins, and we can regain that protein again with Amlexanox. Hurler syndrome is another metabolic disorder leading to severe organ and skeletal abnormality due to enzyme deficiency, and we can regain the function of those enzymes with Amlexanox. Ataxia telangiectasia causes neurodegeneration, immune dysfunction, cancer susceptibility due to defective DNA repair. Possibly we can regain the function of those proteins using Amlexanox, especially if it's nonsense mutation. And certain cancers that is driven by nonsense mutation of P53. That's another way to use Amlexanox to regain the function of PF53 and induce apoptosis. The dosage, we want to use 50 to 100 milligram daily, right? And then based on your response, you can monitor and adjust the treatment. Okay. Number 9, safety and monitoring future directions. Um, what's potential side effects? Well, really, there is not much of side effects. A little bit elevated liver enzyme, but it's not that clinical significant in the epidemiology on the studies. Gastrointestinal discomfort, possible of target immune effect. But most of the patients who received Amlexanox did not suffer from so the side effects is very minimal. And with those dose of 50 to 100 milligram, I think it's a safe dose. But it's good to know that there's possibility you end up with some of those side effects. All you need to do is just wean the patient from the drug or change it. Let's say, for example, if the patients cannot take it topically because of irritation, whatever, you change it in another form delivery, maybe oral or something like that. Or oral, they cannot take it. Okay, you change it into topical, something like that. You can change, maybe loading it with cyclodextrin and lowering the dosage of the amloxanox. That's another option. Monitor requirements, regular liver function tests, glucose and insulin sensitivity markers for metabolic patients to monitor the efficacy of the treatment, inflammatory cytokines to see the response of your treatment, whether those inflammatory cytokines is reduced with time. Genetic and protein expression assay and nonsense mutation. Well, when you take the amloxanox, you will see the expression of the protein is being increased, the one that's being missed by nonsense mutation, and that is showing the efficacy of the drug. So you need to have some objective evidence that this drug is working, and collaborating with the lab to, for example, in case you are trying to manage those nonsense mutatic genes, it's good to see the expression of those genes and proteins through certain labs. Future research and direction, clinical trial. We need many of you here to start using Amloxanox and give us response and feedback, and give us the all the reports, especially the defining the optimal dose response relationship. I mean, those doses that we give is coming from researchers, but it's good to see if we can increase the dose more than that and still the patient can tolerate it and efficacy is there. Combination therapies with immune checkpoints inhibitors. When, as we say, when we're managing cancer, you need to work with combination therapy, not monotherapy. So, using checkpoint inhibitors, metabolic drugs, and RNA basic therapeutics for cancer is very critical. And encapsulating those drugs into cyclodextrin, I think it's the way to go. Now, yes, I'm producing those articles from AI, but the AI needs to learn my method and my direction and my and human intelligence in order for him to customize your lecture in the way that you want it. Like I never mentioned about cyclodextrin, but this AI, he learned that I like the drugs to be loaded cyclodextrin, so he puts it. Um, the AI knows that when I manage cancer, he likes me to do multi-therapeutic combination. So he adds that. So that's the beauty about artificial intelligence. It's like your assistant who will help you, read you, and express exactly what you think, your thoughts, because they have memories as well, and they look at all your inputs and then based on that they reshape and produce the article on the information the way that at the same time they verify it scientifically. They don't just put it like this. If it's scientifically it's not correct, they will say this is wrong or they will not type it. Conclusion: Amloxanox is multifunctional therapeutic agent with a broad application beyond its original indication, which is first it was used for in the United States for aphthous ulcer, and then in Germany and China, and sorry, in Japan they used it for allergies and obesity. Its ability to modulate inflammation, improve metabolic dysfunction, and restore protein synthesis in nonsense mutation position it is as a promising candidate for metabolic syndrome, cancer, chronic inflammatory disease, and genetic disorder. And we need to have more clinical research needed to establish its full therapeutic potential and protocols. I think we're done with the lecture. Anybody has questions? Oops. We have 15 people here. Questions? Stefan, do you have any question?
Yeah, Dr. Halasa, I've used this drug for patients and it's very mild. They don't notice it as strong as other things like Zyrtec. I've had patients, with vaccine MCAS syndrome, lots of hives, itchy, itchy, itchy. We tried Amlexanox. It just didn't work as strongly as, say, something like Zyrtec. And they're like, why am I paying, $200 with compounding for Amlexanox when Zyrtec, you know, it works.
Yeah,
So
so I don't think it's an adjunct therapy. It's something on the side. You give it to patient with cancer, patient with allergies, you need to give them with other drugs. It maybe help as an adjunct therapy, not the main therapy. That's how I see it.
yeah, not super potent. Why didn't this get mainstream medicine in the USA? It's just in Japan they use it, right?
It's catch and kill. Anything that they see it works, but it does not have, they don't generate money for the big pharma, and they have alternative that generate money, and they see it's competitive, then they will suppress it. Same they did with Methylene Blue and ivermectin, all that stuff.
Uh,
But it's a good drug to be used on the side as an adjunct. It does. I have patients. Um, we give them. They have cystic fibrosis, and since they start taking it, their symptoms is completely almost resolved. Especially for mild to moderate cystic fibrosis. I'm not talking about the severe ones.
yeah.
Dr. Halasa,
Yes.
in my experience, I tried Amlexanox in different dosages for myself when I was trying to modulate the insulin resistance, and I wasn't able to lose any weight. And I also tried it in a couple of patients. And I personally went from 25 milligrams to 60 milligrams 3 times a day.
Right.
For me, it didn't work that much. So I wasn't really impressed.
Well, again, it could be it needs to be given as an adjunct with other drugs, not as the main treatment, so you cannot use it as a monotherapy and say I'm going to rely on Amlexanox. But I think it has some quality there which will help in navigating the pathology of the disease. That's how I see it. But I will not use it as a monotherapy, none for cancer or for genetic disease. But at least, genetic disease, we have nothing there. We have nothing for cystic fibrosis. We have nothing for muscular dystrophy. At least those patients, we can start trying on them and see if we can come up with some even 10%, 20% improvement. It's still, it's still considered work for the suffer of the cystic fibrosis and other those genetic mutation. But I think we need to use it in combination with other drugs, not just by itself. That's how I see it. But that's good. Those feedbacks are very important. It just helps to validate the information that we're learning here, and I like it, whether it's negative or positive. Negative is as important as positive, and we learn from the negative as we learn from the positive. I learned that from Dr. Frank Arson when I was trying to load drugs inside genetics inside red blood cells. It did work with small drugs, but it doesn't work with big molecules like DNA and plasmids because it leads to hemolysis. And so he said, well, those negative results are a good thing. So we know it wasn't work here. So we don't, spend our time and money and effort there. And we focus on things that works. So all this negative results helps us to direct the protocols in the way that we know we don't use it as itself, but it can be an adjunct with other drugs. Any other questions? Are we good? Happy?
I found some research on it with cystic fibrosis. So I guess they're doing some clinical studies. You can do that online right now and find some for cystic fibrosis. As an experience, I've used it quite a bit for long COVID with mast cell activation, and it's always a combination medication. And these patients are miserable, and I've had good results with it, and it's compounded. I wonder what would be your, reason to add it to cyclodextrin? Better product. Yeah, I mean,
Well, again, the cyclodextrin itself, it helps to clear up the fat-soluble toxin. So if you use it for weight loss and you're shrinking the fat and those fat is being shrunk to releasing those fat-soluble toxins, it's good to have something that will chelate them and detox them. That's the reason, not necessarily. And plus, the cyclodextrin helps in clearing up managing atherosclerosis and chelating those plaques that contain those macrophages that in the plaques that contain those oxidized, foamy, inflammatory, and also clears up the inflammatory cytokines. So cyclodextrin is not just a carrier; it also has an active effect as an anti-inflammatory, as a detox, as stabilizing the drugs, especially when you use it. Even it does have some antiviral effect because it helps to poke the membrane of the virus that has the enveloped viruses that has cholesterol. They collect those cholesterols and cause perforation in those viruses, which will blow them up. So cyclodextrin is good in every drug that we are using to benefit from its detoxing effect and boost the efficacy of the active ingredient. Any other questions? Dr. Benoit, do you have anything? Tano? Dr. Benoit Tano?
He's traveling right now. He's in
traveling.
Denver.
Dr.
Okay.
Halasa,
Mario?
I'm on the plane, so I cannot do anything.
Okay. Are you going to be in California, San Diego, and ESLA conference? Anybody is going to be there except Dr. Delal? I know she's going. Anybody else?
I'm raising my hand.
Yeah, we're going to meet there. It's very nice. The Germans, they know how to entertain doctors. They have a cruise and all that stuff. Let me remove the recording so we can have more free time here. Are you stopping the recording?